a discussion of evidence-based policies in controversial areas, so some of the challenges and opportunities that I've seen in urban health and addictions. And I'll be drawing a lot on the work that I've done at the Urban Health Research Initiative at the BC Centre for Excellence in HIV and AIDS. And a big part of what I have been involved in there is the scientific evaluation of Vancouver's supervised injection sites. So I'll be talking you through a bit of that and some of the challenges around implementing evidence-based policies in that area. So I thought I'd begin by backing up and talking about evidence-based policy and its roots in evidence-based medicine. And evidence-based medicine was a term that was coined by a Canadian, Gordon Guyatt and his team at McMaster University in 1992. And they really started a revolution when they published this paper. And what they were talking about and what they were really concerned with was how can we do a better job of integrating scientific evidence and what we know from research into clinical decision-making in a clinical setting. And what they were seeing and what we continue to see are these failures to translate research evidence into practice. So it's been shown that 30 to 40% of patients do not get effective treatments, medical treatments, and 20 to 25% of patients get care that's not needed or that's potentially harmful. So these are the kinds of things that we're seeing over and over again in healthcare, and so there's a lot of attention in how we can bridge that gap. But I think we're also seeing it a lot in public policy, and there's a lot of areas where there's gaps between evidence and between practice. And I think this highlights the example around climate change, of how what we know through science and through research isn't being appreciated and translated into policy. And in the area of climate change, it's for the creation of groups like the Union of Concerned Scientists. And this is a group of scientists that came together from MIT to speak out against misuses of science, they call them abuses of science, and political interference in science. So a lot of attention in this area, but there's also been a lot of attention within our response to illicit drug use and around addictions, and that's an area where the Urban Health Research Initiative has been doing a lot of work in terms of creating an evidence base for how we can respond to the problems associated with addictions in urban health. So what I'd like to do is just give you a bit of an overview of the research infrastructure at the Urban Health Research Initiative, where I've been working for since my co-op placement. It's really based on a network of prospective cohort studies. And the first of the studies is called the VIDUS study. It's our longest running cohort study. It follows 1,100 HIV negative injection drug users, and its sister cohort is the ACCESS study, and it follows 700 HIV positive drug users. So those are injection drug users and people who use crack cocaine or might not inject but use heavy drugs. We also have a cohort of at-risk youth. It's 500 street-involved youth, and a cohort that's dedicated to evaluating the supervised injection site. It's the COC cohort, so the scientific evaluation of supervised injecting, and it follows 1,000 Insite clients that were randomly recruited from the supervised injection site. So with all of these studies, we see our participants on a biannual basis, and they complete a very lengthy interviewer-administered questionnaire. So we ask about their income generation practices, their drug use practices, their interactions with the criminal justice system, as well as any health and social service care that they receive. And we're also able to link this data with a lot of other administrative databases. Some we can link to addiction treatment use, detoxification use, and we can also link in with the BC Centre for Excellence in HIV/AIDS data, which provides all HIV medications and disease monitoring within the province, so we can weave that into all of those programs. And this forms a laboratory and basic science research component, something I'm not terribly interested in and I won't be talking about, but it's something that we do. We do have an ethnographic and social science research component that's woven into all of the cohorts. We're moving into doing some clinical trials and intervention studies. And we do a lot of international activities and collaborations. But what I'm going to be mostly speaking to you about today is our policy research and our knowledge translation activities. And this is something that I've been involved in building at the center and something I'm involved in overseeing. So one of the things that we can do with this research infrastructure is look at really policy relevant questions and look at some of these gaps between evidence and practice. So this was a paper that I did looking at incarceration and drug use patterns. I looked at 1,500 injection drug users and looked at their drug use patterns over 15 years. And what I wanted to see was whether having a period of incarceration was associated with changes in their drug use patterns. Ultimately, we wanted to see a bit of a reduction to show that the policy was working. We couldn't find any measurable impact on drug use patterns associated with incarceration, no matter how we looked at it and all the different statistical adjustments that we made. So this is a study, it's not done in isolation. There's a whole body of research around the effects of incarceration, around addictions, and showing that it's really not the best way of approaching things and not getting the bang for our buck that we are looking for, so to speak. So right now, a recent estimate is that we spend about $570 million incarcerating people for drug-related offenses. So with even the introduction of mandatory minimum sentences, that's going to go up. So it's a lot of money for something that we really don't have a solid evidence base around. Another type of policy analysis that we do, this is something that I did for my co-op. It was my first paper that I did with the Urban Health Research Initiative. And what I wanted to do was look at the drug strategy funding within Canada's federal drug strategy to see if it was aligned with policies that were based on scientific evidence. And what I found was that despite a lot of evidence in terms of addiction treatment and addiction prevention, harm reduction, those are really getting very little support compared to drug law enforcement. And when this study came out, it generated a lot of attention. I think it really struck a chord with Canadians and begged the question of what are we doing with our drug strategy and where is this money going and where is the accountability? The Globe and Mail ran a story saying storm brews over drug strategy. And in a lot of ways there was a storm brewing over the drug strategy. And a few months after this, the federal government introduced a new drug policy that they called it the National Anti-Drug Strategy. And they promised to invest more in drug prevention and drug treatment. So we redid the analysis and we looked at where the funding was going, and we found that it was essentially the same. So I do want to step back and talk a little bit about the role of science in policy, and I'm certainly not here to say that science should dictate policy and that's all there is to it. You all are better informed than that. But science does have a role in advancing our human understandings, and evidence-based policy is really about getting policies that meet our objectives, and a big part of our objectives are improving the health and well-being of individuals and society. Now, policymakers, there's many reasons why they might not follow evidence. Evidence isn't always clear. It's not always economically feasible. But what I really want to emphasize is that those decisions have to be transparent and that there should not be the use of deception around them, and that these are the kinds of things that really hinder the advancement of evidence-based policy and our ability to put in the kinds of policies that we need that get to our outcomes. There's been a lot of examples where the use of science has been distorted. This is an example again from climate change, and the government representatives are asking scientists, now could you please rephrase your findings and make it vague, and so on. The tobacco industry is another place where we've seen a lot of misuse of science, and these two researchers are trying to put the spin that it's actually really good that smokers don't die of age-related illnesses. And the example that I'm going to be speaking to is around the supervised injection site, and this was an area where the science around evaluating the supervised injection site has been distorted and misused, and in my view, and I hope you'll see in the end, I think a challenge to evidence-based policy and how we can respond to the problems associated with addictions in urban health. So I want to step back and just give you some context for why we came to have a supervised injection site. In 1996, we had a huge outbreak of HIV among our local drug user population. It was measured at about 23% prevalence, which is really only seen in parts of sub-Saharan Africa, or in the hardest regions of Africa. We also had a drug overdose epidemic happening. This is some figures from the BC coroner showing drug overdoses increasing over in the 1990s. And this picture is a demonstration that a local drug user group, the Vancouver Area Network of Drug Users, put on, where each cross represents a preventable overdose death that happened in their neighborhood. And so they were calling for supervised injection sites for interventions to address this problem. There was also and continues to be a very open drug scene in the downtown east side, people using drugs in open settings. These are very unhygienic settings, and we've been finding that people who are using in these settings, they inject more quickly and they don't take the proper precautions, which leads to injection-related infections as well as other health issues. So there's a lot of reason to get this off the street, which was why in 2003, Vancouver Coastal Health, along with, they partnered with a community organization, Portland Hotel Society, and they opened a supervised injection site, and they needed to get an exemption from the Canadian Controlled Drug and Substances Act. So they got an exemption, And a key part of the exemption was that there be a rigorous scientific evaluation that go along with opening the facility. And that's where the BC Centre for Excellence in HIV and AIDS came in, because we had an established research infrastructure there. That's where we had VIDUS, which started in 2006, so that cohort of adult injection drug users that we were seeing on an ongoing basis. So we had information going way back, starting in 1996, about drug use patterns. And so we applied to Health Canada, and we got the contract to evaluate the site. The main objectives of the site were to address public disorder issues, to reduce transmission of infectious diseases, to try and link people with health services. So this is a population that doesn't get access to a lot of services. They don't necessarily fit well with existing healthcare, and they really are often left out of the healthcare umbrella. So it's trying to see if we could bring them in by bringing healthcare to them through an injection site. And we also wanted to reduce overdose deaths. Now the evaluation we knew at the time would be very controversial, and so instead of doing something like having a final report given at the end of the evaluation, the evaluators decided that what they would do is they would submit all their research findings and their research protocol to the scientific community. So the scientific community would review it and would vet it, and only things that appeared in peer-reviewed scientific journals would be considered part of the evaluation. So to date, there's been over 40 published studies looking at various aspects of the injection site. Many of them have been published in top medical journals, including The Lancet, the New England Journal of Medicine, the British Medical Journal. I'm going to give you just a few highlights. I'm not going to go through all of them, but just to give you a sense of the depth and the breadth of the evaluation of the evidence around it. So one of the first things that we looked at, or that they looked at, was whether or not the injection site was attracting the intended population, whether or not it was getting the high-risk people who are at risk of overdose and at risk of HIV, and we found that it was. We also looked at whether or not it reduced HIV risk behavior. So this is a big part of what the injection site was trying to do, and we found that by coming into a clean place, not only were they injecting more safely while they were at the injection site, but this also translated into injecting more safely outside of the injection site. Partly because of that function of bringing people into under that healthcare umbrella and having them have contact with nurses. There's a nurse on site at all times, an addictions counselor on site at all times. We also found that the injection site was associated with increases in safer sex through use of condoms, and that's another some of the materials that are available when people go to the injection site. We found that the injection site improved public order, and this was just immediately around the vicinity. It's important to keep in mind that the injection site is just a pilot facility. It's not a comprehensive program. So, it's certainly not going to address all the public order issues in the downtown east side, but it did have a measurable impact right around the facility. We also looked a lot about its effect in terms of getting people into addiction treatment. And what we found was that the more that people were coming to the injection site, the more they were having contact with the addictions counselors that were there, and the more they were going into detoxification treatment and longer-term residential treatment. And then what this paper showed was that those folks were then more likely to stop injecting drugs. So while some people would think, oh, well, this is supporting drug use, it's making it easier, people are going to use more, we found that when we're bringing people into a safe place where there's counselors, it's actually having the other effect of bringing people into addiction treatment and helping them to have periods of not using drugs. We looked a lot at overdose risk. Our most recent paper, which was published in The Lancet, showed that there was a 35% reduction in drug-related deaths right around the facility, and outside in Greater Vancouver there was a 9% reduction, so a very significant change right around the injection site. Also, there's been no overdose deaths in the supervised injection site, despite thousands of overdose events. So they really are preventable when you have medical attention right away, and that's something that the supervised injection site can provide. It's also been shown to have a unique effect for females who are injecting drugs. Women are particularly vulnerable when they're out on the street, so this was a qualitative paper, and women were saying in their own experience and in their own voices how it was a unique intervention for them and why it was important for them. We also looked at many aspects of how it increases access to medical care, or if it increases access to medical care, and we found that it did. Indeed, it did. There was education going on in terms of vein care, and as well as lots of referrals, and having a nurse on site. There's a medical room, and so people could get if they had infections, they could get them changed, they could get them attended to before they turned into bigger problems. So there was a lot of medical attention happening at the site as well. And we also found it was an important tool for local police, and this was a paper that looked at whether anybody had ever been referred to the injection site by the Vancouver police, and we found that 17% of our sample had. So the supervised injection site is a unique intervention in that it allows the Vancouver police another tool when they have very limited tools around public disorder in the neighborhood, and that they are using it to refer people and creating a unique public health policing partnership, which are hard to come by in drug policy. We also looked at whether there was any negative effects associated with the injection site. We found that there was no changes in community drug use patterns, no increases in initiation into injection, and there was no increases in drug-related crime. A number of external evaluators also looked at the cost effectiveness of the study, and they found that it was very cost effective, really any way that you diced it. So as health researchers and as program evaluators, we've dedicated a lot of time into knowledge translation. So what we could do to make our research findings accessible to people in policy or to other knowledge users or people in the community. So within all of the Urban Health Research Initiative, we engage in a lot of different activities. They range from creating plain language summaries to publishing commentaries and editorials, both in popular venues and also in academic settings. We do a lot of media engagement, a lot of presentations and personal face-to-face meetings with policymakers and with stakeholders, and a whole host of activities to try and engage people who would use research so that they know about it and they're informed about it and they know how they can use it. Now, specific to the supervised injection site, this is a paper where we summarized all of our activities that we did around the supervised injection site, and I'll walk you through just a few of them. A big part was media engagement. So the lead investigators for the evaluation participated in hundreds of media interviews, and there was over a dozen press conferences that happened throughout the evaluation, really as a means of engaging the public and trying to inform the public about what the findings were and the discourse around the evaluation so that they could understand what it was about. And we found that the media was very interested and very willing to talk about it and to print stories about it. Another big part of what we did was plain language summaries and just translating those sometimes complex research findings into easy plain language. So this is an example of a one-page plain language summary that we did for that overdose paper that I was talking about. So we hope that people, when they look at it within just a couple seconds, they can see what the study was about and what the findings were. We also synthesized large bodies of evidence into plain language summaries. So this is a two-page plain language summary of all the research around the supervised injection site. And we also did a larger report, so it was about 30 pages where each page summarized one study, and we had pictures and quotes from the qualitative interviews to illustrate the experiences of Insite clients. So after the first 3 years, there had been over 20 peer-reviewed scientific studies published that really showed that the injection site was meeting its stated objectives and there was no measurable harms associated with the facility. There was also broad-based support for the site, so the Government of Canada, the City of Vancouver, lots of medical bodies, and public opinion was also very strong. This is a poll that was done by Decima in 2006, and it showed that across Canada, support for supervised injection sites was at 60%, and in BC it was 71%. So as evaluators, it became clear that the supervised injection site was meeting its objectives and it should remain open. The same standard you'd use for any other health program. And at this point, the people who were running the site, Vancouver Coastal Health and the Portland Hotel Society, applied to Health Canada and the Minister of Health to get an extension for the exemption to the Controlled Drug and Substances Act, because that's what they needed to continue to operate. So they put in this application and they were waiting to hear. And during this time, despite broad-based support, there were people who were very against the supervised injection site, and one of them was the RCMP. So at this point, they commissioned 2 separate reports to review all of the evidence, review the evaluation, and see what the reports came up with. Now, both of them were very positive. This is he's a Simon Fraser University researcher, and he concluded that the initial assessment of outcomes has been consistently positive. He then says there's little to criticize or express caution over in the methodologies reported in the publications. So both of these, there's another one as well, they were both very positive, and the RCMP didn't share them, they just kept them to themselves and thought that that would be it. The reports were leaked to the media, and when the media reported on them, they issued a statement saying that the reports did not reflect their views and they did not support them and distanced themselves from those reports. A few days later, the Canadian Police Association came forward and said that they also did not support supervised injection sites. They claimed that it increased crime in the city, didn't provide data about what this increase in crime was, and probably didn't read the study that used VPD data, Vancouver Police Department data, and showed that there hadn't been an increase in crime. But nevertheless, they issued that statement, and then later that afternoon, Health Canada came out with their decision about the exemption and whether or not they would issue the exemption. And the Minister of Health at the time said in this press release, quote, "Do safe injection sites contribute to lowering drug use and fighting addiction? Right now, the only thing the research to date has proven is that drug addicts need more help to get off drugs." He then deferred his decision. He said he was not going to issue an extension, but he would decide within a year and a half, and he placed a moratorium on any new injection sites. So it really gave the impression that he wasn't convinced by the research, and the state of the injection site was really left in limbo. So an interesting development happened a couple months later when this paper appeared in a new journal. This was Volume 1, Issue 1 of the Journal of Global Drug Policy and Practice, and it was a critique of all the Insite research that had taken place to date. The author claimed that the evaluators had misinterpreted their data, and that in fact the supervised injection site was causing a lot of harm. He doesn't provide evidence as to what this harm might be, and it's also interesting that he's never conducted any research involving human subjects, so this wasn't his area where he had been doing research previously. So if you look a little bit closer into the journal, while it appears that it is a credible scientific journal, if you look at their mandate, they weren't so discreet. They said that their institute is charged with creating and strengthening international laws that hold drug users and dealers criminally accountable for their actions. The institute supports efforts to vigorously oppose policies based on the concept of harm reduction. If you dig a little further, you'll see, and you don't have to dig very far, but they're funded by DrugFree America, which is a very well-known lobby group. So I know with all of your training, if you came across an article like this, it would not take you long to see that this is not a credible scientific critique. This is, yeah?
Very quickly, who is this fellow who wrote the article?
I'm Googling him right now.
Colin Mayhem. He's very against supervised injection sites.
Is he an academic?
He's an academic who's never researched. He's not a researcher, but he has a PhD, and he's very involved with DrugFree America.
Okay.
Yeah. So I would expect that you would all quite quickly see that this wasn't a credible scientific critique, and I wish I could say the same about our Federal Minister of Health at the time. But a couple months later, he said, quote, "There's been more research done, and some of it has been questioning of the research that has already taken place and questioning of the methodology of those associated with Insite. Clearly there's a public debate going on, and clearly there's an academic debate going on." So when he was asked to further clarify what this academic debate was, he did refer to that Colin Mayhem article in the Journal of Global Drug Policy and Practice. To make it very clear that there was no academic debate going on, the scientific community the next day released this commentary in Open Medicine, and 130 prominent scientists across Canada signed onto it and said there is no academic debate going on. They said the data to date show that Vancouver's supervised injection facility is an intervention that reduces drug-related harm with no discernible adverse consequences. Period. I think it became really clear. I mean, it was maybe clear before, but now it was very clear that the government was not interested in scientific evidence. It didn't matter how many studies came out or what they showed or how strong they were, or that they were published in the Lancet and published in BMJ or published in the New England Journal of Medicine. So it was at this point that two community groups and two individuals sought legal counsel, and they launched a lawsuit in BC Supreme Court. And they launched it on two fronts. The first was a charter challenge, and what they said was that the supervised injection site is a healthcare intervention, and so closing it down would risk lives and harm health, and that would be a violation of the Charter of Rights and Freedoms as it pertained to security of the person. So there's a charter challenge, and there's also an interjurisdictional immunity challenge, and they said that again, the supervised injection site is a healthcare intervention, so it should fall under the jurisdiction of the province and shouldn't be subject to federal interference. So the BC Supreme Court heard the challenge, heard the case, and they came out with their judgment in May 2008. And the judge ruled that Insite was a healthcare facility, and he ruled that closing it would violate the Charter of Rights and Freedoms in terms of that security of the person. He dismissed the interjurisdictional immunity argument, but based on that charter aspect, he granted Insite constitutional exemption to the federal drug laws. Not surprisingly, our Minister of Health did not like that. He continued to say that there was uncertainty around the research, and he asked the Minister of Justice to appeal the decision, and the decision was appealed. Now, during this time, it then came out that great critique, the one piece of evidence that suggests that there might be some uncertainty or there's some academic debate going on, was commissioned by the RCMP. So further, giving us evidence that it's a biased article and it shouldn't be considered seriously. Now, the BC Supreme Court of Appeals then came with their decision, and they ruled in a 2-to-1 majority both in favor of the interjurisdictional immunity argument and in favor of the charter challenge. So they basically said Insite is here to stay on a permanent basis any way you cut it. Again, the federal government did not like that, and they appealed it to the Supreme Court of Canada. And that was the judgment that we just got this September. So what this judgment said was that they dismissed the interjurisdictional immunity argument, but they ruled in favor of the charter challenge. And what they said was that essentially the minister had to grant an exemption for the supervised injection site. And they said it in these terms. The minister's failure to grant an exemption to Insite contravened the principles of fundamental justice. Insite has been proven to save lives with no discernible negative impact on the public safety and public health of Canada, where, as here, a supervised injection site will decrease the risk of death and disease, and there is little or no evidence that it should have a negative impact on public safety. The minister should generally grant an exemption. So clearly a victory for the supervised injection site, and I would say a victory for evidence-based policy. I think it was a good decision. I think it was the right decision. But I trust that many of you would have the same feelings that I do, that it's a shame that we have to go through legal action to get evidence-based policy in this area, and we would hope that evidence would be integrated into policy without legal action, without claims like this. It's also, I think, important to say that the supervised injection site is a small intervention. It is not a panacea. It serves a very important purpose, a very good purpose, but there's so much more that needs to be done, and our energies and our attentions have really been taken off focus with all of this debate and discussion around the future of the supervised injection site. So in the next bit of my presentation, I just want to talk about what I see as some of the opportunities and where I think we should be looking to in terms of intervening and in terms of policies for addictions and urban health. One area that is a big emerging issue that I think we're really falling short on is how we're addressing crack cocaine use. This was a paper where we looked at crack cocaine use over a 10-year period and among our cohort and of injection drug use, and we found that between 1996 and 1999, the rate of frequent crack cocaine use, so participants who were smoking crack on a daily basis, was at 11%, and between 2003 and 2005, almost 40% of our sample was smoking crack cocaine on a daily basis. So a huge increase in crack cocaine use. And then what we looked at were the risks associated with crack cocaine in those separate periods. And what we saw was that in the most recent period, the risks of becoming infected with HIV were way higher for crack cocaine smokers. So this says that they are 4 times more likely to become infected with HIV compared to injection drug users that weren't smoking crack on a regular basis. When this paper came out, there was, again, a lot of debate and discussion about, what could we do? What are the kinds of policy responses we could pursue? And our BC Medical Health Officer was supportive of looking into the idea of an inhalation room. It's something that would be modeled on a supervised injection site with that idea of bringing people under that public health umbrella and connecting them with health and social services. So to follow up, I did a study to look at willingness to use a supervised inhalation room, and what I also wanted to see was whether people who were smoking crack in public areas would be willing to use it, so whether or not it could address not only those public health concerns, but also those public order issues around public drug use. So we started out by asking crack cocaine smokers where they use drugs, and we looked at those people who are using drugs in public, and 61% of our sample was using crack cocaine in public. We then asked this group, if there was a supervised inhalation room available to you, would you use it? And 71% of our sample said that indeed, yes, they would use a supervised injection or a supervised inhalation room. So there is a potential willingness among the population who's creating street disorder and also who's at high risk for HIV and other harms to be brought into a healthcare environment. Another area where I think we need to put more attention, where I think we've lost our focus in spending too much time on the supervised injection site, is around housing and the links between housing and drug-related harms. This was a paper that I did, and this was connected to my capstone, and it was looking at public injecting in the downtown east side. And what we found was that people who were injecting drugs in the downtown east side were almost 7 times more likely to be homeless. So a very clear link between what we see as the harms or the bad aspects of addiction and housing. I then wanted to look at this a little bit further, and so I looked at the amount of time they were spending socializing in the open drug scene and their access to private space. So we looked at how many hours people reported socializing in the open drug scene, and we found that about 43% of our sample was spending 3 or more hours each day socializing. And we found that having limited access to private space was independently associated with socializing in the open drug scene, and it was the factor that was most strongly associated with it. We then asked if they would spend less time socializing on the street if they had more access to private indoor space, and 65% of the sample said that they would spend less time on the street socializing if they had more access to private space. So again, this connection between housing and another tool that we could use to address some of the problems where I think typically we look to criminalization and drug law enforcement, and there's other opportunities. We did one other paper just to see if trying to address street disorder would benefit individuals who are engaged in it, or whether or not it was just this for the society and for the greater good. So in this paper, we asked people the number of hours they spent on the street, and we divided it into 4 categories so we could compare risks among high drug scene exposure people, moderate, and low. And what this figure shows is that the more time people spent in the open drug scene, the more likely they were to be high-intensity drug users, to engage in drug dealing, to have encounters with police, and to be a victim of violence. So the risks associated with spending all that time on the street were very high. Regular employment and addiction, being recently in addiction treatment, appear to be protective factors. But again, this just gives more weight, I think, to the importance of addressing, if we can address street disorder through things like housing, that it has a double benefit. The other area I'm going to touch on briefly is around income generation and employment opportunities, and how this could also be a big tool for us in how we address some of the problems associated with drug use. In this paper, we looked at the income generation strategies of people who use drugs, and we found that very few engaged in regular work, but it was quite common to engage in sex work and drug dealing. And so we asked these folks if they didn't need money for drugs, are there any of these risky income generation practices that they would give up? And we found that there was a lot of people who really would be willing to give these up if they had other opportunities, other options, and they didn't need money for drugs. And this was a finding that was of interest to the recent Missing Women's Inquiry, and was brought up there and discussed there a lot about issues around sex work and sex worker safety, and was picked up by the media in October. So the last study I'm going to show you briefly is just to take that idea of income generation a bit further and see if people were offered low threshold employment, whether that might reduce their engagement in risky injection or risky income generation practices. So we said if you had casual work that didn't interfere with your welfare, and I thank John for making me think of that welfare bit from my economics. would you be interested in that? And then if so, would you give up any of these riskier income generation practices? And we found that a very large proportion of the group really was interested in giving these up if they had other casual, low threshold work opportunities. So in conclusion, there are still many gaps, I think, between evidence in many areas of public policy, and while these are particularly pronounced, I think, in our response to addictions and urban health, they're really evident in a lot of other areas of policy. And we're going to need to be very innovative and look to novel solutions to address urban health issues, and also to try and bridge this evidence policy gap. Unfortunately, I think efforts to politicize science have become more prevalent and more sophisticated and are undermining our ability to pursue evidence-based policies. But I think the training that you guys are all getting is so important, and I think you guys are going to be really good consumers of science, and I think the more that we can have policymakers and policy analysts be really good consumers of science, the more we're going to have the kinds of policies that we need to improve health outcomes on an individual and a societal basis. So with that, I just want to acknowledge all the study participants that have been part of our cohorts, and in particular also Drs. Thomas Kerr and Evan Wood, who are the directors of the Urban Health Research Initiative and the principal investigators of the evaluation of the supervised injection site, and our funders and lots of other people. So I'm really excited to have been presenting this to you guys. You guys are policy people, and it's a treat for me to get to talk to you guys all about it. So I'm really curious to hear what you have to say about it, and I'm happy to answer any questions that you might have. And thanks so much for having me and for coming. I know you guys are all super busy, and it's been great. So